Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Well, hey, everybody, and welcome back to another episode of Boombostic Health here. I was thinking this is episode 15. Very excited to have Dr. Kenny Bozorgi, who is a friend and also an entrepreneur in the healthcare industry. Has really had two careers, both that is a practicing physician in gynecological oncology, a very specialized niche. That's obviously an incredibly important area of medicine. And then has grown a fantastic ambulatory surgery center business, which is big in this whole trend of getting care more out in an ambulatory setting and away from that high-cost acute care, more risky environment of more of a hospital setting. So super happy to have Kenny here. He also is in the Chicago area where his business resides, and really glad to have you here in the studio. Thanks so much.
Thank you. It's great to be here. Appreciate it.
So your bio is incredibly impressive, and rather than try to convey all of that information, I thought I'd let you do it. And also, I'd love to have you include what was it that got you excited about healthcare? Why did you go into the healthcare industry starting out when in your education?
Sure. I to some extent, it's what I knew. Both my parents were physicians, and interestingly enough, incredibly entrepreneurial at a time when there wasn't a lot of entrepreneurism going on in medicine. Healthcare sort of been in our family, but my father got interested in ambulatory surgical centers and developed one of the first ambulatory surgery centers in the country.
So at that time, it was a novel idea.
Very much, if not an idea that nobody thought could ever happen.
So early 70s.
Early 70s.
People are getting surgeries in hospitals.
Absolutely.
And he all of a sudden just thought there's a better way, or what do you know more of the backstory on how that happened?
Yeah, he came over from another country, and so kind of didn't grow up in the U.S. healthcare system and had no kind of boundaries on the way he was thinking about care. Okay. And in his mind, it made sense to take care into a more efficient, more personalized, frankly, setting. And so that was his goal kind of from the get-go.
And where was that first surgery center?
That was here in Chicago.
Was it really?
Yeah. And it was one of the first couple in the country.
Okay.
Yeah.
So do you know about the story in terms of, were there moments where maybe it looked like it wasn't going to work?
Absolutely. He was met with a lot of, no way. It doesn't make sense. Why would you ever take care out of a hospital? It doesn't make sense to take,
when it would
to
probably
be outside.
threaten a lot of the existing establishments.
Oh, absolutely. But, it was the right time. The 70s, I think, I remember it as a child, but people were more willing to look at novel ideas. And I think it was starting to dawn on it was on the conscience of the U.S. healthcare system that they needed to make changes. And I think that was the perfect setting.
Okay. And early 70s, how is that timing relative to Medicare and Medicaid sort of becoming the norm? Do you know?
Well, it was really sort of more in the 80s, as I understand it, that became
so the whole payer model was different.
Payer model, it was fee for service, mostly commercial payers, and he faced an uphill battle to really get people to get their heads around taking care of patients outside of a hospital system. It was different for the, public health system. It was different for the accreditation organizations. It was a brand new model, and I give him all kinds of credit.
It's amazing. So, and then you decided to study medicine, become a physician. Talk about your undergrad, Georgetown. It sounds like you were a pretty decent student.
I tried, did my best.
He graduated with honors. Let's be clear.
I went to medical school and did my residency here in Chicago at Northwestern, and actually it was during my fellowship at MD Anderson in Houston that I really saw how involved physicians could be in the business of healthcare. Physician involvement is the cornerstone of everything at MD Anderson, and that really got me motivated. And early in my career, I had the opportunity to be the clinical practice director of a brand new division of gynecological oncology.
Oh, I didn't know that.
I was relatively young, so I came in with a lot of different ideas, really focused on enhancing access to care, more timely care, optimizing patient satisfaction, and really opening up the communication with referring physicians, which is particularly important as a subspecialist. And that was a great opportunity for me.
So that's as opposed to having these siloed handoffs where it's not as much of a care team, it's more of just a cog in the machine.
Absolutely. And the other, I think, really kind of important piece for me was that was right when Epic was being rolled out at that institution. And all of a sudden we had the tools. I was involved in rolling that out at our division. I was involved to some extent in the hospital rollout as well. And all of a sudden we had this wonderful communication tool where everyone could be on the same page and we could enhance care by doing that.
And this was Epic?
This is Epic.
Okay.
Right.
At MD Anderson.
Yeah, this is after MD Anderson, part of Evanston Northwestern Healthcare.
Okay,
And this
that was once you got to Northwestern.
This is around 2002 or so.
Okay, I got that. No, it's interesting. We had a guest on the podcast at one point where we were talking about how the electronic health record has created this foundation, and then there's so much more that you can do with it now that data is digital. At one point, there were still paper charts you were pulling off of a shelf,
absolutely.
which wasn't that long ago.
And I give a ton of credit to MD Anderson, too, because they had an electronic health record for many years before that. So actually, I got used to it at MD Anderson, and then came into what was really next level, which was Epic.
Okay, great.
Yeah.
So you went through becoming a doctor. You practiced medicine for quite a while. How and when and why did you make the transition into the ambulatory surgery center space?
So my family was still involved in surgery centers.
Okay.
They were at a point where they were going to relocate some centers, implement some growth strategies, actually acquire some centers. And that was a perfect time for me to get involved. I got myself educated. I became a certified administrator in surgery center. It's a designation that came about in the mid-2000s.
Okay.
So 2008, I got educated and have really focused my career on that since.
Okay, very cool.
Yeah.
So was it tough to make that choice to go away from practicing medicine and getting into more of the administrative and business side?
Absolutely, super tough. I love taking care of patients. I mean, really, that's what got me into healthcare. I enjoy that interaction. I enjoy being involved in that, very special, sometimes difficult time in people's lives. But I felt like I was able to step out of the forest a little bit, and kind of see what was happening at a higher level.
Okay, so moving into zoom out because you had been so focused on that one specialty inside of healthcare.
And I really got the bug being the clinical practice director. I got to direct the protocols and processes that I believe improved care.
For sure.
That was
well, and it sounds like a good business opportunity, candidly.
It was great.
If there's no margin, there's no mission. And it is the case that in an ambulatory setting, you can probably do things maybe in a bit more specialized, personalized way.
Absolutely.
That you've done. So the ASC space has really grown since the early 70s when it wasn't even really a thing.
Leaps and bounds.
Yeah. What has been that rise like? How substantial is the ASC now in the overall fabric of the U.S. healthcare system?
Sure. So, just to throw out some numbers, about 30 million procedures are cared for in surgery centers for outpatient procedures these days. They take care of 50 to 60% of outpatient.
That's per year?
Care.
30 million?
30 million, yeah.
Wow.
And so 50 to 60% of outpatient procedures are now performed in a surgery center. You go back 40 plus years into the early 80s, it was only about 17%.
And the distinction is whether the surgery center is within the four walls of a hospital or outside of the four walls, or how do you, like if I'm a hospital and I own an external surgery center, that's still an ASC, right? It's not about who owns it, or how do we define this?
Sure. So I think the definitions that are probably most important are hospital outpatient department, which is really the ambulatory care portion of a hospital within the walls on the campus, and an ambulatory surgical center, which is off that campus, separate and distinct. And that's an important distinction because reimbursement is entirely different, both from CMS as well as commercial
If
payers.
you're in the hospital or connected to the hospital, it pays a lot more money. Is that
30
right?
to 50% more.
And what's the basis for that?
Well, it's a good question. And that's something that I think advocates and policymakers need to address.
I think
because
theoretically, it's that hospitals are supposed to be taking care of more of an indigent, underserved population as well, so they need more money to do it, or is it just because they need to build buildings? Or I guess we don't know. It's probably a sensitive topic.
Well, I think it does relate to the bigger mission, no question about it. But it is the same care happening in both places. So you don't have, neutral site paying. You have two different tiers, basically, that are providing the same care. So I think that that's a challenge.
So make sense.
For
Make
surgery
that
centers.
make sense.
Okay,
right.
sure.
Okay. Well, I do love controversial topics, and that one's a very controversial one. I think the reality is that, and we've seen this recently with this tragedy with United Healthcare, the whole process of how things are paid for in healthcare, about how we present information to the actual insured about what's going on. I think a lot of it is people don't like the anxiety of not knowing or understanding.
Absolutely.
It's so complex and opaque. But could I also say, though, that as an independent surgery center, you probably are operating in a more efficient way than inside a hospital?
We are. I mean, there's no question. And that's because we're focused.
Sure.
We're focused on outpatient care only. We are not taking care of patients for emergencies. We don't have an inpatient unit, all those sorts of things. And that's been proven over and over again in healthcare. When you do the same thing over and over again, you get more efficient. We're smaller.
Sure, and you can put
more
all your
personalized.
resources and energy.
Absolutely.
And I recently visited your surgery center, and I saw that it felt really comfortable. You guys are investing not only in the fact that you have the right instruments and technology from a care perspective, but also just the environment felt like warm and inviting, different than an institutional.
The mission is to be a welcoming environment, easy to navigate. You show up and you already know some of the folks there. We're making calls in advance. And you're going to see, if you come 2 or 3 times, you're going to see the same people over and over again.
Sure.
Which is nice.
That is nice. It's more comfortable. It's interesting. I'm a terrible golfer. Okay. And somehow I've been playing golf my entire life, and I'm still terrible at it. I think it's one of those things where I wish somebody had taught me how to do it the right way to begin with. But once you develop all these bad habits, it's hard to fix it. But anyway, I enjoy it. And I belong to a club that it's only golf. So it's not a country club where they have a pool and they have all these other activities, tennis, whatever. It's just golf. And lo and behold, because it's just golf, it's absolutely fantastic at putting out a great product for people who really love to golf.
Makes sense.
And it does. It makes so much sense. And it also cuts back on a lot of the other things that suck down the budget. So there's no assessment for we need a new pool or any of that.
Right.
And it's a simplified analog to what you're talking about, but you can go all in on making it so that this surgery center is better than others because it's your focus. So is there continued growth? Have we already seen a point, 30 million patients a year? Is this continuing to grow?
The expectation is that the predictions are, annual growth of 6%, at least for the next 5 years or so. Over the last 15 years or so, there's been about 20% growth from about 5,000 surgery centers to over 6,000.
Okay.
Every year, more cases are being approved to be performed in a surgery center by the Centers for Medicare and Medicaid Services. That means that every year, the pool of cases which can go into a surgery center expand. That list trickles down to what commercial payers are willing to approve. And ultimately, that leads to higher acuity cases coming into the surgery center. So, yes, the growth seems to be something that's going to continue for quite some time.
So there is a place and a time for that in the hospital
absolutely.
Sort of surgery scenario. Absolutely. And then there's a bright line probably where it moves over to this is something that can be performed in an ASC. What is the right kind, or the kind of surgery that really doesn't work in an ASC?
Well, there are two sides. And we started talking a little bit about individualized care. So it's not only the procedure, but the patient, right? So there are certain patients who have illnesses or pre-existing conditions that would require or should have the resources that a hospital would have. So it is the patient.
Like an ICU and that sort of resource? Or when you say resources, what are you thinking?
Other specialists, the ability to intervene in the setting of, for example, a pacemaker or something like that. There are,
Like an organ transplant.
well, there are definite cases that should not be done in an outpatient surgery center. Any case that is expected to require hospitalization, for sure greater than overnight hospiitalization, absolutely is not eligible for a surgery center.
Okay, so that's a good way to think
That's
about it.
kind of a bright line.
Okay,
right
if you
there.
require hospitalization, you're having the surgery in the
Absolutely.
hospital, they wheel you up to the
Right.
other area and you stay over. Okay.
And there's some patients who will have the same procedure, but one does need to stay overnight and another patient doesn't. And that's related, again, to physical status, other medical conditions, that sort of thing.
So in the ASC industry, is there a lot of private equity kinds of owners? You folks are independent, which I think is,
We are.
is pretty cool. How do you think about the owners of surgery centers, how you would see yourselves as different from like a PE owned, or are there, I just read a report recently actually that Emily sent me about the downside of a lot of the PE ownership in healthcare.
Sure.
And I'm not anti-PE. In fact, I do PE investing. So it's just more of an interesting thing to assess and understand. How do you distinguish the way that you're set up, and why haven't you sold out to PE, and how does that fit into the overall ASC environment?
Well, we don't have some of the advantages of PE. We don't have the capital backing that they do. We don't have some of the scale, the enterprise, systems that a PE can bring in, with a rollout. On the flip side, though, there is a fair amount more autonomy. Doctors who are also allowed to be investors in surgical centers because of a carve-out from the anti-kickback statute at the federal level are able to have a lot of input. And it's a different feel. We're able to pivot quickly. We're able to do a lot of things that I think would take a lot more kind of permissions in a larger organization. That's kind of where it's at. But to me, surgery centers are a great place for PE to address these recent studies because they're places where they can do well with their investments that also make a positive impact in care, I believe. And so there is additional investment going on, especially as private equity groups are buying more and more surgical subspecialists, ophthalmologists, ear, nose, and throat doctors, that sort of thing. Then owning a surgery center makes a ton of sense.
Yep.
Another revenue stream, another way to utilize their capital.
So this whole ASC concept sounds like a great idea. Sounds like it's good for patients. Sounds like it's good for business.
Yes.
It sounds like, gosh, maybe I should just go open up a couple dozen of these. What are there's got to be something to it, right?
Sure. So there are regulatory hurdles, financial hurdles. Regulatory is a good place to start. About half the states are certificate of need states, which means that you have to go through a formal government process in order to get an approval to open your doors. It's highly regulated across the board, but that CON is a barrier to entry. It's a double-edged sword. It's hard to get in, but it also is protective.
Is that Illinois?
Illinois is a CON state.
Okay.
Whereas some neighboring states, Indiana, and other states are not, more ASCs in general. And in some studies, having more competition has led to decrease in costs too. So, there are pros and cons to the CON process as a whole.
So how is the pricing set for the ASC services for the self-pay versus the commercial insurance? What's the mix look like on both sides of those? And is it pretty price competitive, or how do you think about that economic engine that keeps everything going?
Well, the way that we think about it is always to be competitive, and part of our mission is access as well. So on the self-pay side, we actually do a pretty deep dive into what is the market rate for any given procedure. We look at what commercial payers are paying. We look at what Centers for Medicare and Medicaid Services are paying, and we come up with a fee schedule based on that. And the Centers for Medicare and Medicaid Services have a clear fee schedule. Again, that's different from a surgery center versus a hospital outpatient department and that sort of thing. With commercial payers, it's contracting. And that's a challenge for surgery centers, especially in independent ones. We're smaller. We don't have the volume. We don't have the clout of the hospital system when we get, contracted. And that in and of itself is a bit of a challenge. The CMS rates have gone up 1% to 2% on the average annually for surgery centers, whereas they've gone up 3% to 4% for the hospital outpatient department. Those are pressures that are real on surgery centers, whether you're independent or not. So again, there are challenges, but the goal is to create a fair fee schedule that's transparent too. We've early on, prior to the No Surprises Act, there was complete transparency at the centers that I've run, and I believe at most centers in terms of what the fees are going to look like.
So up front, the patient is aware of
Absolutely.
What's getting paid by insurance or not,
Yes.
what it's going to cost.
Absolutely.
So there's not the big surprise bill after the fact.
No.
You say, where'd this come from?
Absolutely. And in a formal process, not kind of a loosey-goosey. Self-pay is a very formal process. They receive an estimate. They know exactly what the fee is going to be. Their doctor has made an assessment of how long it's going to take. That drives that. Anything extra is kind of laid out in detail.
Got it.
In writing.
So there's actually a document that lists everything out and tells you what the price is. Kind of like a regular business where there's like an invoice.
All
That's cool.
Compliant with the No Surprises Act.
Yeah, good for you. So value-based care is a concept that I keep thinking about as you're describing the ASC world.
Right.
It seems like value-based care would be a tailwind for this.
Absolutely.
Is that fair? How do you think about that? And is it part of your strategy that you talk about?
So I think surgery centers are built for value-based care. On the CMS side, they have the bundled care initiative, which is all about allowing prediction in what the costs are going to be. That's a program that is, I think, exciting. Total joints are often bundled care approach to care, but for commercial payers also, there's simply if you provide better outcomes, then patients, then the reimbursement's better. So value-based care on both the government paying patients and also non-government.
And how are those outcomes reported to those entities?
We report to multiple different databases.
So on an ongoing basis, ordinary routine part.
At the state level, at the federal level. Surgery centers are regulated essentially the same as hospitals. We have at least in Illinois, most of the same reporting requirements. Both if you're Medicare or Medicaid certified, you report all of your outcomes. And there are certain outcomes that are have a brighter light shining on them than others, but we report all of that. So surgery centers are highly regulated.
And is there a ranking somewhere where I could say what are the top performing surgery centers and see that stack ranked? Or
I am not aware of anything like that. No.
Okay,
but
is that publicly available?
It's publicly available data. Yeah,
that's interesting.
Yeah.
So
I'm not familiar with an aggregator or someone who's.
Do you look internally at how do your quality levels compare to others in the industry?
Absolutely. The ASCA, the Ambulatory Surgery Center Association, they have benchmarks. We're involved in their benchmarking studies annually. We, benchmark against centers of similar size, similar case mix, all that sort of stuff. So that data, those data is readily available, and certainly, we are aware through other publications sort of what the benchmarks are. But like any other business or healthcare organization, you have to benchmark yourself.
Yeah, absolutely. So there's a lot of innovation taking place across healthcare.
Absolutely.
And a lot of the viewers and listeners here of this podcast are people out there looking for opportunities and making moves to innovate. What are some of the innovations that you're seeing in the surgery center world?
Well, I think it's easy to start with AI and data-driven changes that we're seeing. In the last couple of years, I've seen a number of ASC-specific technology companies come about in order to do things like overlay AI in surgery scheduling. And in some studies, you can improve cancellation rates by 20 to 30% by overlaying AI model on top of your surgery scheduling. In terms of materials management, overlaying AI allows you to better manage, more efficiently manage, decreasing costs up to 15 to 20% as a result. And just having the data to help you predict clinical outcome is super important. That's, those are, I think, that's a whole host of innovations. What's built into the surgery center model is the ability to bring in more complex patients every year as technology improves in care and as technique improves. That's a built-in innovator. Every year, there are cases that were not able to be performed in a surgery center last year, and they are able to be this year. And that's those are the two biggest innovators, I think.
So it's interesting, the examples you gave about staffing and other examples that are more operational supplies. They're not necessarily the Star Trek, this changes everything, but that's the blocking and tackling that's actually making the business better. And I think those examples actually are the ones that exist all over the place that most people don't really think about. A lot of times when people think about AI, they think about 2001: A Space Odyssey and HAL 9000 going haywire, and that's a totally different realm than these focused workflows and different mechanisms to make it so your staffing's better, which is probably one of the biggest costs that you have.
Absolutely.
And it's hard to match that up.
And surgical OR utilization.
Yeah. Okay.
That is absolutely critical. That's why I started with surgical scheduling. We have 7 operatories at one of our centers. It's critical that we're efficient with it. They're not running 24 hours. We want the patient and the physician experience to be good. We don't want them waiting. But on the flip side, we don't want empty ORs either. Right. So that's one of the reasons I started with that. And that's often overlooked, I think.
Yeah. And what are all the specialties that are being covered in your centers?
So both of our centers are multi-specialty. We do everything from cosmetic plastic surgery to ear, nose, and throat, to gynecology, to podiatry, to orthopedics, to ophthalmology, pain management, gastroenterology, just name a few.
Well, I assume that you probably also tailor just like you're tailoring things to the patient, you tailor it to the surgeon.
Absolutely. The surgeon, we have 3 customers. We've got the patient first and foremost, we've got the payer, and we've got the surgeon. Our goal is to provide a more efficient care model for not just the patient, but for the surgeon. If they can do 1x procedures in the hospital, they should be able to do 2x with us.
Okay.
Plus, they're going to see the same team day in and day out. It's not a team of 50 who rotate through. They're going to see the same faces. What that means is, and again, proven over and over again in healthcare, when you have a team that works together on a regular basis, you do better for the patient, better outcomes, more efficient care.
You're more coordinated. You know what the person really
You played a team sport. If you're playing with the same folks on the field, day in and day out, it's better than when you're playing with folks that you don't know.
There's no doubt about that. So when you look forward at the overall national landscape for the way surgery gets delivered, is there some point out there in the future where it's almost all done in more of an ASC, and other than just the super high risk, highly acute kinds of issues that require that hospitalization? Because even for the hospitals and health systems, they're trying to get patients out of the hospital.
I think that there will always be cases that require procedures and patients that require multi-day hospitalization. I think that will be difficult to change. Having said that, number of days in the hospital have decreased significantly. So the trend is that way, but I don't think the hospitals are going anywhere. I think that their inpatient days are going to go down as expected, but I think there will always be room for that. And the flip side of that is that the outpatient care is going to continue to grow. Again, improved technology, improved technique, healthier patients.
So do you ever get contacted about being part of a private equity type of a roll-up platform?
I do.
Yeah.
Yeah.
And that's just not a great, you don't need that. Or what's your thinking? I'm just
Well,
thinking about an entrepreneur who's out there running their
Sure.
service center. There's always that question about, do I continue to grow this? Do I decide to sell it? What do I do?
Well, I think the landscape's changing. I think the pressures are more significant now. I think that we're looking more closely at that maybe than we had in the past, but we continue to be successful and we continue to be able to provide great care. It takes a lot of work, but we're able to do that. But I think there are great opportunities in that regard as well. I've been involved not in the ASC business, but on the hospice side and rollouts, and I've seen what great things private equity can do when done the right way. And so it's not rejecting them out of hand, just maybe not the right group.
Right. And you're a family business, effectively. Is that a fair way?
We have been to date. Yeah.
Is that something you envision as a continual process, or?
Not through blood relatives. I don't think that that's going to happen. But the reality is, all of the leaders that I've been working with for 15 years, and we have great retention, they're like family now. And so our hope is that they continue to move things forward.
Very cool.
Yeah.
That's awesome.
Yeah.
Well, it is so interesting to hear about this ASC world and just even the certificate of need issue. Which one other follow-up question on that? Mm-hmm. So once you have a CON, can that be taken away from you? And
it's actually, I mean, it certainly can be taken away and if you do something egregious, but the reality is that CON is based on need in that given area. You are the protector of that need in that area. You literally can't close in Illinois without getting approval to give that CON back. And so it's a very strong competitive advantage. And it comes with a lot of responsibility also. And that's how we view it. So as I said, it's a double-edged sword. You can certainly close, but you have to show that the need that you are providing is going to be cared for elsewhere.
And just because I never said this at the beginning, I don't think you did either. What are the actual names, or what's the name of your surgery center?
Mm-hmm. So our surgery center in the downtown Chicago area is the Surgical Center at 900 North Michigan Avenue. It's a surgery center that we got involved in about 27 years ago. It had been built by a health system and struggled for 10, 11 years, losing money. And we were fortunate enough to buy a great physical plant and a great location. And through our relationships in the area, bring in a lot of physicians, both independent and employed physicians who worked at academic hospitals in the area. Magna Surgical Center is in the Bedford Park area. It's sort of a different mix of patients, more ophthalmology, less cosmetic surgery. And we started that de novo, I use we loosely, but in 1987, and relocated that about 12 years ago.
Fascinating. So the concept and the knowledge about the surgery center industry really came from your father getting started there.
Absolutely.
But the businesses that exist today aren't just a continuation of what was started in the early 70s. It's new.
Over time, we've sold some surgical centers, acquired, and then sold. Magna Surgical Center was built, the new one, de novo. So we've had, a number of different experiences.
Yeah, so it's an entrepreneurial journey, and
Absolutely.
There's never a crystal ball.
And there are right times to sell, as we've shown with a couple of the centers. But with the centers we have now, we feel like there's lots of growth potential still, and it's exciting still.
That's awesome. Well, I am so appreciative of you joining for
Thank you.
This episode. Really amazing to learn from you, and appreciate the friendship. And also, we're investing together in some pretty cool companies that are helping to apply data and these signals and AI into making healthcare better.
Yep.
So it's always great to have partners that have the kind of background you do in delivering medicine and doing right by patients. So
thank you.
Thank you
I
so much for
appreciate
being here. Yeah, and thanks everybody for joining for this episode. We will now transition to The Verdict with Emily to talk some more about the legal and regulatory implications of being in the ASC business. Hey everybody, welcome to The Verdict with Emily. We just had this great conversation with Kenny Bozorgi, a physician who has gone into the family business of owning and operating high-performance surgery centers, in particular ambulatory surgery centers in the Chicago area. Really fascinating to hear how his father got started in that space in the early 70s when that was like a completely novel concept. Now we've got 30 million procedures a year going through United States ASCs, so certainly a proven part of the overall healthcare ecosystem, and one that is highly regulated. And there's a lot that goes into getting one of these stood up and running and operating them. Love to have the verdict with Emily here, where we can gain some perspective on just what the nuances are of being in this space, and if somebody's considering it, why they might want to think twice, because it's complicated. So, Emily, what do you think?
It is complicated, particularly when we talk about states where there's a certificate of need, like in Illinois. He touched on that briefly, but certificates of need, the intent of a certificate of need is to make sure that you're not watering down and sort of having too many of the same service providers in an area. People who dislike certificate of need say it's maybe just another regulatory hurdle that you have to get over and a way for the state to make money. There are some disadvantages associated with certificates of need. Typically, it's like less access to care, longer wait times, things like that. But nonetheless, there's a ton of states that have them. You have to deal with it, especially if you're in Illinois. The other issue associated with ASCs is typically an ASC has some sort of joint ownership amongst either multiple groups of physicians, maybe different specialty areas. Sometimes there's a minority hospital ownership. And so as a regulatory attorney, when you are presented with how do we do this, the very first question you have to ask is, what are the financial relationships? And so when you have competing groups that are going to be referring to a jointly owned facility, that impacts what you can do and can't do under the Stark Law, of course, the anti-kickback statute. And then the downside is, if you set it up improperly and you're billing incorrectly, then you have significant risk under the False Claims Act. So it is a highly regulated space. The billing for an ASC is more akin to like hospital billing, facility billing, than it is the traditional provider fee for service. So there's certain things that are baked into the rate that the ASC gets for, it's like a per procedure rate that factors in, anesthesia, maybe some pre-op labs, things like that. But ASCs are great. They, it's a highly regulated space, but when you talk about like the care that can be provided in an ASC, as he noted, there's certain things you can't do, right? Like if somebody has, a heart issue or they're on blood thinners and there's a risk that they're going to bleed out, that person should be having surgery in the hospital where there's access to additional care. But if you're having, knee surgery, why not go to an ASC where you get it done right there? There's, it's a more intimate service setting and you get discharged and you get to go home. From a provider perspective, you have to be careful to make sure that when deciding who's eligible for the ASC facility versus a traditional hospital setting, that what the potential quality outcomes are, because then you have to have transfer protocols in place. You're not allowed to keep a patient overnight in an ASC. So that is something worth considering. But, the benefit of the ASC is it makes some of those more routine day surgeries a lot more accessible.
It's interesting. This is an area where I think regulations around how healthcare can be practiced and paid for and who can make money does become interesting or nuanced, complicated, because in certain respects, you have to be careful that the physician isn't doing extra surgeries because they make money also from the technical side, from the actual facility fees. On the other hand, you hear, well, you have to actually be a physician to own one of these, or physicians have to be involved somehow. So if you have physicians and you have a surgery center business operation, how does that work? Who has to own it? Does a physician need to be involved? How can the physicians be compensated? Like, can the physician make money from the technical and the professional fee?
So that is going to be state dependent. Who can own the facility goes back to the concept of corporate practice of medicine. So that's going to vary by states. Most states are going to require some sort of licensed personnel to own the facility. But it is different because it's, a facility as opposed to a physician group. Compensation gets really messy with ASCs and like who can benefit. And that takes into consideration who's referring. So to your point about like driving surgeries to a facility, if I own an ASC and let's just say I'm a GI doc, right? And I'm referring people to the ASC for procedures to be done, there might be a better facility at which a patient could have those services provided, but I'm referring them to my practice, whether or not I even, actually am doing the procedure at the facility, right? I might just be an owner. But I'm referring them to my practice because I'm financially incentivized to do so, because if the person has a procedure there, I make money. So that's what the intent of the healthcare regulations is, to try and cut back on that type of inducement. I say this all the time when I talk to my clients, especially like my lab clients. They always say, well, if I would have known all this, I wouldn't have gotten into lab work. Well, nobody told you had to get into lab work. And this isn't like selling cars, right? Like there's the downfall of financial relationships in the healthcare space is very different than a financial relationship amongst car dealers, right? Nobody's necessarily getting harmed by a financial relationship with a car dealer. When you have patients getting referred for services that either are not medically necessary or the services are being performed at a facility that's not the best facility for that patient, that particular patient to have the services, there is an argument that the patient can be harmed by that, right? So we have to think about it differently. People tend to get real frustrated with the healthcare regulatory framework. I will admit it's a bit behind the times, but it was put in place for a reason, and it's to protect patients and make sure that there isn't overbilling that happens, whether that's to the commercial payers or, to the federal government, and then the taxpayers are the ones that are harmed by the relationship.
Okay, so to summarize, it's important to have a specialist who does this regulatory work day in and day out that is helping to set things up and then continuously reviewing where you stand, because these laws also change over time. So it's not a simple answer, and it's not the target is moving.
Exactly. And it's getting even more complicated because there's a lot of PE interest in ASCs right now, which is exciting. But as we've previously talked about, there is PE scrutiny as well. So it'll be interesting to see what happens there.
Yeah, you shared that report with me. Who was the publisher of the report about the private equity investments in healthcare? It was the government study. Do you recall?
That was the Senate Budget Committee. I think it was Senator Glassy. Don't quote me on that. I have to double check that. So that report was published early January, which was really interesting because it was a bipartisan report that it looked carefully at PE roll-ups and what it meant. And there were negative consequences that were discussed in the report. And the negative consequences were decreased staffing, increased negative quality outcomes, increased cost to patients and to payers. But the flip side of that is, I also think for like every report that there is something like that, there's an equal report on the other side that says, hey, this PE roll-up in this particular space created access to funding that improved care because we were able to hire quality specialists and it decreased negative outcomes. So I think you have to be careful with those types of reports. But nonetheless, I think the takeaway there is the government is watching these to see how it does impact patient care.
Yeah, and in that case, it's similar to any Malcolm Gladwell book where he can do a great job of creating a position and convincing you based on analysis that position is 100% the only true position. And like you say, there are multiple sides to that. Well, super interesting topic, a critical part of the overall healthcare fabric, our surgery centers, and really great to have Kenny Bozorgi here to talk about his experience, which has been incredibly successful at providing high quality patient care, great access to care, and something that I hope will continue on for a long time because we need more people like that are in the delivery of healthcare. So thanks so much, Emily. I appreciate you being on, and look forward to seeing everybody out there next week for our next Boombostic Health. Have a great day.